Good evening, everybody. Good evening, Dr. Manish. Good evening, Aishwarya. Dr. Hirsch is just joining in. He's having some challenge with his technology. Dr. Manish, you are on mute at this point.
And I think we have around 2 hours. And I'm sure the program won't run into 2 hours, isn't it?
Yeah, we have kept for 2 hours. We will start with just giving some brief directions on the way the program is going to go, because there is a specific area where the participants will be getting to participate in a quiz, and which would be held at the end of the program. Just a moment, please. Hello. You have the link. It has come in your email. It is just sent to Dr. Harsh. Yeah. Okay, 1 minute. I'm forwarding it to you once again.
So can you share? Also, Jayanta.
Sometimes technology doesn't work. The Dr. Hirsch's mail has not reached. Just reconfirm. You got it? Yeah. I have sent you a mail. Just see. Yeah, it is there at the bottom. On the YouTube network, and there's also a NutriQuiz for the quiz participation. Using
Okay. Hi, Kiran, can you hear me? Kiran?
a template on Slido platform and also to their individual register. Okay, and then we will start.
Dr. Harsh, we are able to hear you.
Thank you. Thank you. Because I was wondering whether I'm audible at all. I'm sorry
Yes,
for
sir.
joining late because I was struggling with the link. So, Kiran, we starting in what, 10 minutes?
No, we can start now based on the
Attendance?
yes, we can start.
Can we, since I think we have excess of time, so why
Yeah,
don't we wait for some more of participants to join? It's only 23 that's people are there. You
yeah.
said there are 168 registrations. I understand many people register, but they don't join actually.
Correct, correct. No, but we have currently how many people have come on the
23.
registration, but how many are there on the Zoom platform?
23 right now, Kiran.
23. Okay, we'll wait for a couple of minutes. Maybe by
Yeah.
Yeah, 5 more minutes.
5:10 we can start off. 5:10,
Yeah,
5:15.
5 minutes.
That should
Fair
be
enough.
good.
Fair enough. Fair enough. Yes. So, we have something here on the screen. I need to close this one. I'm not able to do it. I have an additional slide deck on, Kiran. I'm just trying to close it.
So we have time for the 5 minutes, so we can just set up all the.
Yeah. So I think now this is open, right? So this stays open, and this is how it is. Uh, Share Windows. This. Now, is it visible, Kiran?
Yes, Harsh,
Yes.
it is visible.
Yeah,
Your
it's
Now it
visible.
is full screen, right?
screen.
Presentation mode. Fair enough. Yeah. This is the point where I'm going to give it to Dr. Munish Karunakaran to take it further, right?
Right.
We close it. Hmm. Minimize it. Minimize. Okay. But we still need to have it in full mode, right? So it's minimized. Fair enough. Yes. So Kiran, we are 6 minutes past 5. So 5:10,
5:10
5:15,
we'll start. 5:10,
5:10.
5:10 we can start off. Because
Okay.
the presentation would possibly will take about 10 minutes for the introduction, 5 to 10 minutes for the introduction, and then handing over to Dr. Monish. Once Dr.
Okay.
Monish finishes the introduction of Whipples and gives his talk, he'll be handing over to Dr. Aishwarya. So back to you, and you can hand it over to
Right.
Aishwarya. She will then
Fair enough.
present the case.
Fair enough. Done.
We
Let's
expect
get
that the whole thing should be completed by about 6 o'clock. The presentation, and then we can have the quiz, which will take about 10 to 12 minutes for all
it.
participants to participate in the quiz. Thereafter, immediately the results will also be announced.
Fair enough. So once we are done with the presentations and everything, then I have to hand it over to you for the quiz part? Because you
No,
said
that
that.
will also get immediately published, so you
Okay.
can see the and then we could also if there are any questions which we get from the participants, since Dr. Munish and I will be available, they can share the details about this also.
Fair enough. Fair enough.
If any of the participants have any questions which are not related to the
Interest
quiz
or
but more
something.
to
Okay.
the case and to the procedure, they can get that clarified as well.
ठीक है, ठीक है. So another 2 minutes we get going. Done. A very good evening, ladies and gentlemen. This is Dr. Harsh Chaturvedi, representing Pulse Nutriscience, welcoming you on behalf of the organizers, my organization Pulse, to this very exciting evening where we are going to be talking about nutritional management following Whipple's procedure. Subsequently, there will be a quiz as well, which you would be participating in. But before that, we'd like to get some insights from Dr. Monish Karnakaran on the Whipple's procedure, and then subsequently from Dr. Aishwarya on the nutritional issues and consequences. As I understand, the Whipple procedure is a commonly performed for cancers, especially of pancreatic, head, ampulla, distal bile duct, and duodenum. And it does involve removal of quite a substantial part of the gastrointestinal tract. But yes, there is also a reconstruction procedure which is there in place. But having said that, as I understand, and Dr. Munish can correct me later, uh, even though we are able to reconstruct it, but normal coordination between food, the digestive enzymes, the bile, and the intestinal hormones, it all gets disrupted, and which results in not only impaired digestion, a significant nutrient malabsorption, weight loss, and vitamin deficiencies. Having said that, we are going to have first Dr. Munish talking about the procedure, and Dr. Aishwarya subsequently on how to manage this. Uh, Dr. Munish is known widely uh, as a surgeon of eminence. Uh, I don't need to really introduce him, but it is customary. Just a second to do this. No, it should be open. So, what this? No. Yeah. So I'm sharing the profile of Dr. Munish. I hope my slides are visible to you. Dr. Munish Karnakaran is a consultant surgical gastroenterologist and HPV surgery, liver transplant at ICRA International Hospital and Research Center at Kozhikode. He is a senior lecturer, MD Advanced Studies at Flinders University, Adelaide, Australia. He is a member of Research Committee and of Asia Pacific of HPBA, member International HPV Association, Asia Pacific, and Indian Pancreas Club and NISPEN. He is part of the editorial board of British Journal of Surgery. Dr. Munish has authored more than 25 articles in peer-reviewed journals on pancreatic, hepatobiliary, and liver surgeries. Dr. Munish is also a recipient of IIP 2023 Young Investigator Award and a AP HPVA 2025-26 research grant. With these words, I welcome Dr. Munish to our program today. And I would also welcome Dr. Aishwarya Raj PR, who is Chief Clinical Dietitian, Continental Hospital, Hyderabad, India. She has more than 17 years of experience in clinical nutrition. She is the Executive Committee member of IAPN Hyderabad chapter, a life member of IDA, IAPN India, and ISPN, Associate member of International Society of Hypertension. She is a presenter at PENSA, IDA, IAPN, and AICNU conferences. She is a recipient of multiple national awards in clinical nutrition and nutrition innovation, Best Clinical Dietitian Award in 2024, and Quality Improvement Champion Award in 2024 at Continental Hospitals. I welcome you, madam, to this program. I also take this opportunity to talk a bit about my company, which is Pulse Nutriscience. We are an innovative nutraceutical company which specializes in science-backed disease-specific nutrition formulas for clinical nutrition, wellness, and weight management. The company operates a state-of-art manufacturing facility close to Hyderabad with a monthly capacity of 75 tons of spray-dried powders and 150 tons of dry blend powders. And we have a growing presence across Africa, Asia Pacific, Eurasia, CIS, Middle East and North Africa, and Latin American markets through strategic global partnerships. With these words, I welcome you again to this very exciting evening where we are going to learn a lot by listening to Dr. Munish and Dr. Aishwarya. So now it's time. I think without much ado, I will hand over the session to Dr. Munish, who will be deliberating on Whipple's procedure, giving us some insights, what exactly is done and how we go about it. And subsequently, Dr. Aishwarya will bring about the nutritional aspects, what are the challenges and what happens there. It is over to Dr. Munish. Dr. Munish, your audio needs to be switched on. We can't hear you. You need to unmute yourself. Have we given you the publishing rights, Kiran? We need to check because yes.
Kiran, I'm not able to hear. Yeah, I mean, but I'm not able to move my slides.
You need to get to the reading mode at the base of it. There are slides on the screen, but you need to get to the base where you will see the page, the reading mode kind of a thing.
We're able to hear you, Dr. Munish. Or alternatively, do you want? Yeah. Do you want our team to present the slides?
But I'm not able to do that. Yes.
I think your internet is showing a little bit of a weak relay.
Okay then. I mean, I'm happy for the team because
we're able to hear you, Dr. Munish.
Yes. Are you able to hear me? Yeah, great.
Yes.
I'm not able to run my slides. I don't know why.
Okay, Dr. Harsh, if you have the slides,
Yeah,
can you
yeah,
just share it?
I go
Dr. Harsh will
to.
share the screens.
I'm just opening it. Just give me a second.
Can you see my screens now?
Yes, we can see your screen. Yes, we can see your screen.
Yes. Right.
Should I present here?
No. Dr. Monish's screen is visible.
Okay, fair enough.
Okay.
Yeah. Okay.
So basically, it's a cover page of that this thing, the whole program, right?
Sorry, come again.
Dr. Harsh.
Yes, doctor, you can go ahead.
Yeah, go ahead.
Yes, thank you. So thank you, Dr. Harsh, for a very kind and generous introduction. Good evening, everyone. At the outset, I would like to thank Nutri Health Foundation and Pulse Nutrisciences, especially Mr. Kiran Das and Dr. Harsh, for arranging this opportunity for me. We have this exciting presentation by Ms. Aishwarya on the management of nutritional challenges in a Whipple's procedure. So without much ado, let me set the stage. Procedure.
We have lost you, Dr. Manish, somewhere.
Dr. Monish, your audio is broken.
Saying that it's one of the most technically demanding, or rather one of the most gastroenterologist. In short, gallbladder, the distal bite, it generally never gives me problems. Actually. Is it better?
Oh, we can go to the earlier one. You can manage here. It's okay.
Okay, right. So, yeah, as I was telling you, it entails removal of the head of pancreas, the duodenum, the gallbladder, the distal bile duct, the distal portion of stomach, and the regional lymph nodes. So, when is it indicated, or when do we do a Whipple? It is most commonly done for tumors involving the head of pancreas and the periamplar region. I will explain what is the periamplar region using this diagram. As you can see here, let me take the yeah, this is the stomach. This is a duodenum. It's a gallbladder. It's a common bile duct. The common bile duct and the pancreatic duct, they joint and then jointly drain into the duodenum. The structure through which they drain is called the ampulla of Vata. You can see the enlarged image in the second picture. Now, Whipples is generally done for all periampullary tumors, that is, the tumors that involve the distal bile duct, the pancreas, the duodenum, and the ampulla. So, when we generally talk about tumors wherein a Whipple is required, we talk about pancreatic tumors and the periampullary tumors. But here you can see that even, so let's say there is a tumor over here, which is well within the 2 centimeters of the ampullary region. So even some pancreatic tumors will be classified as periampullary tumors. So with this basic knowledge, we all know that 60 to 80% of patients with pancreatic and periampullary cancer have significant malnourishment at diagnosis. And nutrition status represents a pretty much modifiable determinant of outcomes that follows a Whipple's procedure. So again, I'm sorry for the lack of quality in the pictures. I could not get a good picture from the internet, so I drew it myself. So yeah, here you can see the stomach. This is a normal anatomy. This is a stomach. This is a liver. This is a right hepatic duct. This is a left hepatic duct, which joins to form the common hepatic duct. This is a gallbladder. The gallbladder again joins the common hepatic duct to form the common bile duct. This is a pancreas. Pancreas is actually behind or posterior to the stomach. Now the pancreatic duct and the common bile duct, they drain together via the ampulla of Vater into the second part of duodenum. And then the food bolus travels from the duodenum. Here somewhere is a second part of duodenum. This horizontal part is called the third part of duodenum. And the final part is a fourth part. And subsequently, it continues as a jejunum. So for any tumor over here, unfortunately, we cannot remove the tumor alone. So we are forced to do this major surgery called Whipple's pancreatoduodenectomy, wherein these lines are the transection line. We transect after ascertaining the resectability of the tumor. We start the divisions. So first division is on the stomach. The stomach is divided. Then the pancreas is divided. Then the jejunum is divided, just distal to the DJ flexure. And the bile duct is divided above the point where the gallbladder joins the bile duct. So this gives rise to 4 cut ends. This is a gastric cut end or the gastric stapled end. The bile duct is cut, and the pancreas along with the pancreatic duct is cut. The small hole represents the pancreatic duct, and we have the jejunal end. The intervenient duodenum along with the head of pancreas, distal bile duct, and all are removed. Next comes the reconstruction part. In reconstruction, we first do the pancreatojejunostomy. This jejunum, this end of jejunum is brought up and joined first to the pancreas. Further, about 20 to 30 centimeters downstream, we join the bile duct to the same jejunal limb. And then further 30 to 40 centimeters downstream, we do the gastrojejunostomy. That's we join the transected stomach to the limb of jejunum. Further 20 to 30 centimeters downstream, we may put a tube, which is called the feeding jejunostomy, which can be utilized if the patient is not able to feed himself via naturalis in the post-operative period. Feeding jejunostomy is not the norm. I don't do it all the time, but yes, in indicated patients, we do it. The indications broadly include patients who are malnourished, significantly malnourished preoperatively, or the patients who have got gastric outer obstruction, or the patients who have got very high risk of a pancreatic leak or a pancreatic fistula following this surgery. So now, makes me wonder why are these Whipple's patients at a very high nutritional risk? There are preoperative factors and there are postoperative factors. Most of these patients have got biliary obstruction leading to jaundice or duodenal obstruction, which impairs the ability to eat, leading to anorexia, nausea, and significant weight loss before surgery. Significant proportion of these patients have pancreatic exocrine insufficiency that leads to fat malabsorption, steatorrhea, and deficiency of vitamin A, D, E, and K. Many of them have brittle diabetes, and many a times worsening of diabetes or sudden onset diabetes is a red flag sign which finally leads to a diagnosis of a pancreatic cancer. And the most important and the most worst is a cancer cachexia, which is a systemic inflammatory syndrome that occurs in cancer that drives hypermetabolism and accelerated muscle wasting. These are the problems that the patient faces preoperatively. Now, on this patient, someone goes ahead and does a very morbid surgery called Whipple surgery, which I just explained to you. Then comes the postoperative issues. Entire GI anatomy is altered, and such dramatic re-engineering changes, along with the loss of duodenum, changes the entire digestive physiology, leading to significant malnourishment. Then we always have complications for him, and not always. A significant proportion of patients do end up in complications. Let's say about 20 to 25% of the patients following a Whipple end up in a complication. And the most common ones are delayed gastric emptying, which happens in about 30% of patients, and for post-operative pancreatic fistula, which happens in about 15% of patients. Now, I don't want to actually scare you about this procedure. This procedure does carry a significant morbidity, as I said, about 30%, but thanks to the improvement in surgical technique, anesthesia technique, and clinical perioperative clinical pathways, the mortality has come down significantly in the last 20 to 30 years, and mortality at the high volume centers is nothing more than 2 to 3%. So, what are the consequences of this malnourishment? Apart from impaired wound healing, immunosuppression, and sarcopenia, there is a 57% increased risk of major complication in these patients. They are twice more likely to stay longer in the ICU, have a longer length of hospitalization, and at a significantly higher risk of readmissions. As I said, told you, the pancreatic leak, a malnourished patient has got 3 times higher risk than a normal patient. And very importantly, they have a reduced tolerance to adjuvant therapy, adjuvant chemotherapy. The patient, from a cancer perspective, benefits only if he or she takes all forms of treatment, including surgery and chemotherapy. Radiotherapy of late has been understood to have no great role in pancreatic cancer, except in the ones which are invading arteries. But otherwise, it's surgery and chemotherapy. So the patient derives benefit of treatment only if he is able to take both surgery as well as chemotherapy. Now, if the patient is malnourished, the chances of him taking chemotherapy decreases by 30%. Even if he takes, he may have interruptions in cycles, which leading to a poor response to chemotherapy, a lower dose of chemotherapy, all of which leads to a decreased overall or a disease-free survival. Yeah. So these are precisely the reasons why we are having this case presentation or discussion here to learn and know how do we tackle these issues. Over to Dr. Aishwarya now.
Thank you, Dr. Munish. It was really heartening to learn that the mortality is reduced to about 2%, if I have not misunderstood, in spite of undergoing such a difficult procedure. And I'm sure not only the post-operative, but this certainly warrants a perioperative optimization, before the patient gets into it and during, and of course subsequently, to ensure the success and a better outcome with such morbid procedure. It was very, in fact, I must congratulate you. Those hand drawings were the ones which helped us really understand the processes. Otherwise, we were all at loss to make out what was happening there. Thank you so much for this. And now I will take questions, ladies and gentlemen, later. I'll invite Dr. Ashwarya to share her presentation and enlighten us with the nutritional requirements. And I'm sure she is touching on both somewhere on peri and post-operative, so that the patient has residual reserve to withstand such rigors, which Dr. Manish has just shown to us, and to successfully come out of them also. It is over to you, Dr. Aishwarya.
Hello, we are unable to hear you.
Dr. Aishwarya, we can't hear you at the moment. You can see your slide on the screen. We can't hear you, Dr. Aishwarya. I hope you are on mute. No, we can't hear you. I wonder if it would be a good idea for you to rejoin Dr. Aishwarya. Are you calling me? Saurabh, are you there with Dr. Aishwarya? Try rejoining. Meanwhile, as Dr. Aishwarya takes time to join, ladies and gentlemen, I'm thinking of just asking, just a second, ladies and gentlemen. Hello. I'm very keen to understand from Dr. Munish, meanwhile, that so what do you see is the biggest concern with this Whipple procedure? Is it post-Whipple procedure? Is it the pancreatic insufficiency, exocrine insufficiency, which is there, or the micronutrient deficiencies and so on and so forth?
Yeah, very good question, actually. The patient suffers from both.
Okay.
However, to reach that level wherein this pancreatic exocrine insufficiency becomes a problem, or nutrient deficiency becomes a problem, he has to go through a lot. Whipples, as you all must have understood, is a very morbid procedure. So unless you prepare the patient for the surgery, they do pretty badly. I was, surprised to see many people operating. If you don't prepare the patient, the results are very bad. So, what I personally do for these patients is when you when I diagnose them, for example, if it is a most of our, luckily for us, most of the tumors in our part of the world are periampullary tumors, not pancreatic tumors.
Okay.
Pancreatic tumor carries a worse prognosis, whereas ampulla has the best prognosis, followed by duodenum, followed by the bile duct. So most of these patients would be jaundiced because since it obstructs the bile duct, most of them would be jaundiced. So first step for them would be a biliary stenting, which relieves them of the jaundice. Once the jaundice is off, they feel like eating. They would engage in some sort of a physical activity. So we used to run a prehabilitation program of about a month or so before we actually used to operate this patient because after doing let's say 1000 or 1500 ripples we understood that it even if we don't operate over the next 1 month or 2 months the cancer probably is not going to kill the patient, so let's not kill the patient with our surgery. To be very simple and honest, this is the message that we got from our when we looked at our data. Henceforward what we started is the prehabilitation program. After that, we had some amazing results when we combined exercise optimization as well as nutrition optimization for these patients. The mortality, I have a study wherein we have compared 150 patients who are prehabilitated versus 250 who have not been prehabilitated. In 150 patients, there's only one mortality. Whereas
Oh,
in those
yeah.
250 patients, there were about seven mortalities. And mind you, we are talking about a center which has already done about 1,500 Whipples. So they are a very high volume center which regularly does these large, high end procedures. Even then, we find it difficult when the patient is bad. So, yeah, if there is one message that I want to convey, everyone is prepare the patient. Without preparation, please don't operate.
That's very critical, because interestingly, just a while back, we
Yeah,
have.
partly my specialty is to be blamed. We're all what we call trigger happy. So, but then it's better not to be trigger happy because you have to kill the enemy. You have to be prepared with your ammunition, and then you should start firing at them. So,
Yeah.
so, so, you know.
Uh,
Yeah,
uh,
I think
yeah, go ahead.
someone asked a question. If someone, we can answer till like,
Uh,
okay. Someone had, I saw one question actually.
I can't. I'm just trying to reach if somebody has a question. Uh, there's some question about steatoria. Presence of steatoria. Shari Ajit is trying to reach us. You are not very clear. You have just mentioned a word. So, what are you exactly looking at? If you can type it again.
Yeah, I'll explain it.
Yeah.
So, steatoria, if you ask me, is it a problem? Yes, it's a problem. But most of the patients who undergo Whipple do not develop long-term pancreatic exocrine insufficiency. But they do have a lot of nutritional challenges in the immediate perioperative period with some amount of pancreatic exocrine insufficiency as well. So, what my practice is, I give all the patients who undergo Whipple or a distal pancreatectomy pancreatic enzyme supplementation for about 3 months. So that is the most difficult period for them. So I try to help the pancreas, help the digestion with some amount of enzymes. Afterwards, it picks up on itself. So long-term exocrine insufficiency is generally, 70% of patients don't develop it. It's about 25 to 30%. But again, this pancreatic cancer or even a bile cancer patient doesn't live long enough to have a full-blown exocrine insufficiency. In our country, the average survival is around two, 2.5 years.
Oh, oh,
So,
okay.
yeah, after going through all of this, the patient doesn't survive more than
Uh,
2.5 years. I know it's a very sad story, but yeah, that, that's how it is as of now.
but I'm sure we would have progressed, somewhere from Maybe earlier it would have been much worse than what we.
Yes. Oh, definitely.
Yeah.
We have improved. If we have improved, especially the credit goes to chemotherapy.
Uh,
But yes, still, I mean, it's sad that after going through so much, the patients get to live, let's say, 2.5 years. It's bad.
hmm. So when we are preparing them for the procedure, because I am looking at a very kind of a situation here.
Yeah.
So to begin with, are there any nutritional advices, dietary advices, to build up the reserve, or they are the
Yes,
usual
I
ones?
mean,
We generally talk about carbs and proteins there.
so
Or is
so
there something more to it?
yeah. I mean, I'm sure Dr. Aishwarya must be touching upon this, but what we used to follow was 30 to 35 kilocalories per kg body weight
Hmm.
and 1.5 to 1.8 grams of protein per kg body weight. We used to have a food diary for all of these patients, and we used to look at the compliance. So our prehabilitation program used to be a three-pronged approach. We
Hmm.
used to have exercise prescription, we used to have nutritional prescription, and psychological support. Exercise was the most difficult one to adhere to.
Sure,
Understandably,
sure.
Indians
Yeah.
as such, we are not used to exercising. And then, yeah, I mean, uh, and that too, when you are sick, you ask them to exercise. It's
It's a
most
no way.
difficult.
It's a no way
Yeah,
thing.
nutrition, yes, but the
Yeah.
problem with nutrition is that, I mean, part of the problem is our dietary prescriptions. Don't try to give them too healthy food. I mean, don't try to give them low sugar food, which would be a good prescription for a cardiac diet or a diabetic diet. Here, in the patient is battling cancer. The patient is battling extreme catabolism, and he is not probably going to live for more than 2 to 3 years. So it's not a very intelligent ploy to restrict them of high calorie, high protein diet.
Mm-hmm, mm-hmm, mm-hmm. Okay.
Let If the patient feels to take calories in the form of gulab jamun, let them have it. Don't worry about the sugar status. Don't worry about the cholesterol, because all that are NCDs, not, I mean,
Yeah,
what
they
is it,
are very
lifestyle
secondary.
diseases.
Yeah.
Yeah, I know. That's why I wanted to stress upon this point. Don't let them. Sorry, someone is asking questions.
Sorry, I can hear.
Two name change చేస్తుంది హాస్పిటల్ తరం కొద్దిగా ప్యూర్ హాస్పిటల్ ప్యూర్ ఒకే రెండు వల్ల నాకు పేషెంట్ తెలియట్లేదు అది వేరే
I think I think we can hear somebody else talking.
ఆయన బయోడేటా వేస్ట్ ఫార్మాట్ పెట్టారు అవన్నీ చూసి రాజేష్ కి ఫోన్ చేసి ఫోన్ బయోడేట్ ఫైల్ చేస్తారు ఏమంటే ఒకసారి అని చెప్పేసి చేసిన చెప్తే నేను
Hello, hello. Yeah, I can hear. Yeah, I can read Chandni, clinical dietitian. We can hear you. Hello. Yeah, that's better. Yes, Dr. Manish. So,
Yeah. So
high carb and high protein diet. Yes.
yes. So if the patient wants to have chicken 65, let them have chicken 65.
Mm-hmm.
So, because a patient already has a lot of anorexia, most of them have jaundice, they won't be able to eat the very healthy kind of a food.
Mm.
So let them eat what they like. And not giving masala their khana is actually an antithesis to our Indian habits. How can you eat khana without masala?
Khichdi is not favorite.
Yeah.
Yeah.
So, no, the only problem I find with Indian diet, that too, most of North Indian diets is we go a little less on proteins.
Mm.
Yeah.
But that's true for Indian diets. No, we are basically carbs and fat fellows, right?
Correct. No, I mean, Kerala, I mean, since I'm now in Kerala and I'm from Kerala,
Mm.
we're slightly better. I believe we're slightly better than most of the other states.
Mm-hmm.
Protein, because fish is there.
Yeah.
I mean, most of the Keralites can't go a day without eating fish.
Yeah.
So, which is an excellent source of protein.
Mm.
So,
Hello.
Yes,
yeah.
we are listening to Madam Dr. Munish Rasnakaran.
Hello.
We had some
You are
good
ready, so
conversations.
we can. Yes,
Hello. Uh,
yes, we can hear you, madam.
oh, okay. One second.
Uh,
Mute.
Saurabh, once we are able to settle it, I think we come on screen. Till then, Dr. Karunakaran is speaking to us. I think that would be a better idea. Yes, doctor, sorry for these interruptions. Please, please, please.
Okay,
We have just crossed Gulab Jamuns and
we'll start.
Gulab jamuns and chicken 65 the way to go in a cancer in a patient whom we are preparing him for surgery. Yeah. Second thing, I mean, which I've found is that we have to make them exercise. Most of the people are not able to exercise. So what I mean, the kind of exercise prescription would involve three kind of exercises. One is respiratory training. Second is endurance training. Third is resistance training. So in a respiratory training, most of the people are able to do. We have something called a spirometer. If you have ever been hospitalized or ever been to hospital, you would have seen one cute little thing, three columns with three balls. We ask the patient to blow in and so that the balls get up. So this is a very important exercise to prevent post-operative pulmonary complications. Very common in any upper abdominal surgery, including Whipple's.
sure.
But most of us would be able to do that spirometry exercises. So if you're able to do it, I would rather suggest the patient should start blowing balloons.
Oh, yeah.
Slightly more difficult, and it can build more pulmonary reserve.
Reserve, yes.
Next is endurance training. So endurance training, for the most of the patients, what I advise is I ask them to walk. So we have 4 weeks of this prehabilitation. So in those 4 weeks, the first week I ask them to walk about 10 minutes a day at least. Next week, increase it to 15 minutes. And third and fourth week, 20 minutes in the morning. It's good to climb stairs. It's good to cycle. But most of our patients, I mean, many of our patients may not have a cycle at home. I'm sure most of us don't have an exercising cycle at home. So that's why I stick to the walking thing. Third and the most difficult is the resistance training, but that is the one which is most beneficial.
Yeah.
So for resistance training, what we advise them is we advise them to buy resistant bands, otherwise called TheraBands. They're color-coded bands. The easiest one is the yellow one. As the color changes, the difficulty level as well changes. So yellow, pink, orange, red. So that way. So we can do targeted exercises using those TheraBands, because if you ask them to exercise with dumbbells, most of the patients will feel overwhelmed and they're not going to do anything. Rather than that, what I say is use this band and you can exercise. So that is again very helpful. We have, there are studies which have shown that even 1 or 2 weeks of strength training has resulted in thickening of your diaphragmatic muscle.
Oh, yes.
Yeah, I mean, generally they say that the muscle strength improves, but the volume doesn't improve so quickly. But this study showed that even the thickness of diaphragmatic muscle improves, which is again, I believe a very important measure to reduce pulmonary complications. So you do all of these things. Most of see, the whole point I want to drive in is I cannot promise a patient that he or she will not have a complication. Whipple is such a difficult surgery, such a technically demanding surgery that nobody can promise that you will not have any complication. But if at all you get a complication, develop enough reserve to fight that complication. So that's what rehabilitation allows you to do. And after surgery, I'm sure I don't want to talk about the after surgery thing because Aishwarya would be touching upon those things.
Yeah, go ahead, please. Yeah.
I might contradict people on a lot of things, but yeah, let's keep it towards into the discussion. Another thing that I want everyone to understand is that even after you finish your surgery, you finish the chemotherapy. Again, in India, we have a very bad tendency of staying at home or resting. The word is rest. Resting because we don't have strength after we undergo a surgery, which is a very dangerous thing. Even after surgery, You should exercise, you have to exercise. And if you regularly exercise after surgery and chemotherapy, there are studies which have shown that there is a decrease in cancer recurrence, the survival improves. So yeah, I
Yeah,
think Aishwarya is ready.
yeah,
Yeah.
I think she is ready. We take it further from after her session's over.
Yeah,
So it
sure,
is
sure.
over to you, Dr. Aishwarya. Uh, we got an opportunity to learn a lot from Dr. Manish Vilbai. Yeah.
Yeah.
So please, it's all yours, Dr. Aishwarya.
Yeah. So, good evening, everyone. First of all, sorry that thank you, Pulse and the Nutri Health Foundation and Dr. Harsh and Kiran sir for giving me this opportunity. I'll cover it soon because delay happened from my side. I hope you can listen me now. You can hear me.
Yeah, we can hear you, Dr. Aishwarya. Please
Yes,
go ahead.
yes.
Yes.
So doctor covered almost all the introduction part, so I don't want to repeat the same thing again. But coming to the nutritional assessment, because it's our area, I can start from nutritional assessment. So which kind of assessment we need to do, even it is pancreatic, even if it is any surgery cases it admitted in hospital. Normally, we'll do subjective global assessment and some screening methods like NRS 2002 or must screening. But in particular, like these cases, there is a chance of muscle lossage and sarcopenia. How will we assess that? So now assessments are changed. Like many of we have many options now. So we can easily find out the sarcopenia. We can easily find out the muscle strength of the patient and muscle mass of the patient. So better we need to go with nutritional status should be assessed according to the symptom functions and anthropometry and biochemical values. Only body mass index should not be used because it does not find sarcopenia in the obese patient with chronic pancreatitis. In olden days, even I practiced from when the junior level. So that if we normally go with body mass index, of course, we'll see, we will write all the diagnoses, whatever the food allergies and what are the GI symptoms, everything. But end of the story, we will always see what is the BMI. As per BMI, we will assess the patient and normally will mark like patient is well nourished, mild, moderate, or severely malnourished. But when now we see only BMI means we cannot find the sarcopenia for sure. So malnutrition in chronic pancreatitis shows a varied like presentation with multiple biochemical association. So both underweight and overweight or obesity patient can be malnourished. So higher BMI, reduce the muscle mass, and poor functional status are common. So, patients with chronic pancreatitis are at high risk of malnutrition. So, including altered body composition affecting the quality of life and the post-surgical survival. So, nutritional intervention improves the nutritional status and it may reduce the pain. So, micronutrient deficiencies like B12, folate, vitamin A, D, E, and zinc, selenium, and iron are the common thing. Then, especially in pancreatic and exocrine insufficiency, we need to focus, and clinical sign appear late. So, routine screening we need to follow. So, symptom based assessment we can do. Otherwise, we do have body composition now and ultrasound to find the sarcopenia in some hospitals, and DEXA scan, of course, there, and BIA. So, anything we can use for the assessment. Actually, what is available in your hospital, based on that you can do the assessment. It's not like particularly you need to do. So if you ask me personally, I can say always glim assessment is better than subjective global assessment to find more severely malnourished cases. Like we are very sure that this patient will get already malnourished, or the patient may become severely malnourished for sure after the surgery. Then coming to the but I think doctor already explained. So we can always give the supplement with any of the major meal. It's always better. And coming to the case study, yeah. So this is a 55-year-old male with height of 160 centimeter and weight of 50 kg, and the BMI was like 19.5 and ideal body weight was 56 kg. So he presented with the abdomen pain, vomiting, jaundice, and reflex symptoms, constipation, clay-colored stool, and poor appetite. So most importantly, he had 15 kg of weight loss within 3 months of time. So here we know how sarcopenia. Even the patient just told us like around 15 kg I lost within 3 months. Then only we know how sarcopenic the patient is. So we think to do the glim assessment. By default, we are not doing glim assessment for all the patient. If we feel the patient is malnourished or severely malnourished, then only we'll do glim assessment. So glim assessment showed the severe malnutrition with low skeletal muscle mass, of course sarcopenia, and his nutrition risk score 2002 showed that the score was 5, it indicating the high nutritional risk. Slides. Yeah. So coming to the BCA profile, the body composition profile, you can see here all the red marks. So the body composition analysis demonstrate that very significant depletion of lean body mass, reduced total body water, protein stores, intracellular water, fat-free mass, and skeletal muscle index. So although the body fat mass is relatively preserved, skeletal muscle mass is also compromised and suggesting 100% sarcopenic. And functional assessment using hand grip strength reveals severe muscle weakness. So not only muscle mass, muscle strength is also important. So here only you can see the muscle weakness, how much it is there. So like muscle strength is also like 12.6 kg in the left and 15.2 kg in the right hand. So far below the expected average of a normal adult man is 42 to 45 kg. So collectively, these findings indicate again severe muscle wasting, poor nutritional status, and increased risk of clinical outcome for sure prior to the surgery. So emphasizing the need of aggressive nutritional requirement is our nutritional intervention with follow-up is from this slide only we know it's very much important. So coming to the biochemical parameters, here we can see the hemoglobin levels were low and the patient had different biochemical abnormalities, the consistent with biliary obstruction and malnutrition. So elevated bilirubin and liver enzyme and alkaline phosphate indicate the obstructive jaundice, and serum albumin was reduced, suggesting poor. It can suggest maybe inflammation or because of poor nutritional status. So these findings again reinforce the need of aggressive nutritional care for sure. So coming to the medication, again the medication also show how important the dietitian's role for this case, because the patient received antibiotic, proton pump inhibitor, vitamin and trace element supplementation, and anticoagulants and supportive medications. So these intervention help to manage infection risk, nutritional deficiencies, gastrointestinal symptoms, and post-operative complications. Coming to the 24-hour dietary recall, it's a simple case study like that. I just kept it here, like the normal case study how we do normally. The same pattern I used here, so you will understand better. So 24-hour dietary recall, again the pre-admission dietary intake was very low. So the patient consumed approximately 700 kilocalorie and 22 gram of protein almost daily. This was the previous day intake. So some more the other it is less or plus, maybe the fewer like the past few months. So compared with his estimated requirement, the intake was very poor. So it contribute of course for the severe weight loss and sarcopenia. So again coming to the nutritional diagnosis, the statement, I can see clearly the nutrition diagnosis was Inadequate oral intake related to poor appetite and cancer associated metabolic stress. And our goal were to prevent the further weight loss, correct nutrient deficiencies, and restore lean body mass and achieve positive energy balance while avoiding overfeeding. So requirements were estimated at approximately 1680 kilocalories and 84 gram of protein like a normal requirement. And coming to the care plan, cancer cachexia driven by reduced intake, systemic inflammation, altered metabolism, and hormonal changes. So, therefore, the nutritional therapy focused not only on calorie replacement but also on addressing the inflammation, preserving the muscle mass, and supporting recovery. So, the multidisciplinary approach is essential for successful outcome for sure, because see, doctor can do the surgery, doctor can suggest the how much may be the calorie requirement or protein requirement. They will write it in a note and go. But after that, if the dietitian will take care well, if the dietitian will give a proper nutrition from the day one or from when the feed start, then only it will work. If you are not focusing, I know the dietitian ratio in the hospital, it is like 1 is to 40, sometimes 1 is to 50, 1 is to 70 also. So there is the patient may not get the proper nutrition or proper care for sure. We will miss here and there, but like these surgery cases, if you give the care from the starting, it is better. Suppose you are taking as a case study, of course you will do follow up and you will do very good care. But if you are not doing that in a normal patient, if it is not your case, then you are not going to do that much follow up. I know well, because of we don't have time. But if really care the patient, especially like this cancer cases or post surgery cases, uh, the patient will get 100% benefit from the nutrition part. So be focused on your single patient, not just like normal diet or diabetic diet or renal diet, just doing the counseling and going. That is not our role. We need to deeply interfere with the nutrition, and we should understand the patient side, how much they are suffering, how much they are paying, and what is the result they are getting. Okay, surgery may over, after that they will be fine, but the nutrition part, are they take caring well or not? This both side mistake is there. Of course, the dietitian not only we cannot blame, because the patient will come to the OPD for the review. The doctor of course need to send the patient for the dietitian consultation again for the review dietitian consultation. So if it is an OPD patient, we can write the review, but in IPD case, once discharged, most of the cases will not come back, and the dietitian need to call them back, and if they are really interested, they will come. Okay, so both side mistakes are there. Still, we are in correcting world now, so we will going forward. We'll do better. So, coming to the next slide. This is a beautiful slide. Actually, I'll just quickly explain. So it is showing the contribution of, like, loss of muscle mass and strength. So aging is the primary risk factor. No, aging, sarcopenia I'm talking about. So sarcopenia, aging is the primary risk factor. Then hormonal changes and imbalance occur with age, and altered energy expenditure affect the metabolism. Then low dietary intake reduce the nutrient availability. Then physical inactivity accelerate the muscle wasting and inflammation. So chronic inflammation promote again the protein breakdown. So how it collectively lead to sarcopenia, we understood only from this slide. Then how the nutritional requirement to prevent or to treat the muscle loss, what we can do. So energy needs, of course, 25 to 30 or more than 30 kilocalorie per kg per day. And protein 1.2 to 1.5, we can increase up to 2 kg, depends on the case. Again, higher protein intake support again muscle protein synthesis and preserve the lean body mass. So coming to the key amino acids, like leucine, HMP, and glutamine, and catenin, and creatine. So the dosage is like leucine 2 to 4 gram per day, and HMP again 3 gram per day, glutamine 0.3 gram per kg, and carnitine like 4 to 6 gram, and creatine 5 gram per day. So these nutrients stimulate, of course, the muscle synthesis and may reduce the muscle loss and preserve the muscles. Okay, so we do have many examples with HMB, the preservation of the muscle, like 3 gram per day. If we give proper HMB, then of course the muscle preservation or the muscle synthesis we also find. So it's a good choice. Then omega-3 fatty acid, again fish oil, 2 to 2.2 EPA should be there, like 1.5 gram of DHA. So EPA has an anti-inflammatory effect and may help to preserve preserve the muscle mass, or particularly in cancer cachexia cases. Then coming to the vitamins and minerals, 600 to 800 IU of vitamin D, and yeah, multivitamin also needed. Vitamin D support the muscle function and the bone health for sure again. And coming to the multimodal interventions, of course, nutrition therapy, exercise, and resistant exercise or training needed. Then pharmacological therapy is also important, and psychological support for sure. So this integrate the total approach how to produce the good outcome for sarcopenia. Then coming to the cachexia, we can see most of the cases like how it is happening, the symptom to develop the poor nutrition. So what will the symptom develop the poor nutrition? Loss of appetite, nausea, and pain, difficulty swallowing, and decrease the food intake. Condition causing malabsorption, again pancreatic insufficiency, pancreatic resection, or intestinal resection or obstruction. So coming to the cachexia stage again, cancer cachexia is again characterized by reduced muscle protein synthesis and increase the protein degradation or inflammation. So metabolic abnormalities. So progressive muscle loss or sarcopenia is also leading to cachexia. So unlike simple starvation, cachexia cannot be fully reversed by nutrition alone. The treatment, everything is matter in cachexia. Then coming to the assessment, here is our part again. This is completely showing the how the assessment is we can do for sarcopenia or cachexia cases. So physical examination is very much important, and nutritional screening, nutritional assessment, dietary history, body weight changes or muscle mass or strength we need to evaluate, and functional assessment. So early identification allow the timely intervention. So in this case study, we used this all. That's why I kept this slide. Actually, we did glim assessment, we did BIA, and we did hand grip strength assessment also. So coming to the intervention again, if oral intake is inadequate, then dietary counseling, and he can give maybe oral nutrition supplement, high protein diet and all. If the gastrointestinal function is inadequate, then plan for enteral nutrition when feasible, or else parenteral nutrition. When the gut cannot be used, then only go for parenteral nutrition. So I think you understood from this slide how important to take care of the sarcopenic or cachexia patient. So coming to again the hospital day one, the patient was initially underwent CT scan, biopsy, and ERCPs. Because of that, the patient was on NBM. I think the half day the patient saw the food. Then after from 12 o'clock, the patient was on NBM for the test and all. Of course, the after biopsy they confirmed it, but there was 99% of the chance from the doctor they were expecting. So they were planned for surgery only. They came to hospital, but they were just waiting for the biopsy report. So the biopsy confirmed metastatic ambulatory adenocarcinoma. ERCP standing relieved biliary obstruction and improved the symptom. Subsequently, laparoscopic assisted Whipple procedure was performed, and post-operatively, this patient, the patient developed with pancreatic leak or infection and bleeding. Then patient was in ICU on POD 3, shifted to what? So, post-operative nutrition progression, the feeding jejunostomy started in POD 1, and 25 ml per hour, started with jejunostomy feed with semi-elemental formula, of course, and the requirement was 1680 kilocalorie per day, and the protein requirement was 84 gram, and the 325 kilocalorie and 13 gram of protein we reached, because the feed started by 2 p.m. and the slow volume was there. And the second day, I think POD2, the hospital stay was like sixth day, FJ feed 50 ml per hour, they continued. And by day 8 and 9, the patient was receiving approximately 2300 kilocalorie with 80 gram of protein. It's because of FJ feed increased, and yeah, we are able to, yeah, adjust the formula also. Because of that, they reach the calorie requirement and protein requirement. And coming to the day 10, the liquid were introduced orally, sips of water from the day 8 and 9, and the oral liquid diet initiated on day 10, with along with the enteral formula. So it was like recommended calories like 1960 kilocalorie per day. Because the patient was malnourished in the severely stage, we started with low recommendation. Then we increased when the feed is getting tolerate. We know that the requirement was high, so when the feed is getting tolerate, then we increase the calorie, but protein remains the same, like 84 gram, because reaching that target only, it was little tough for us. So, and overall that the patient started with oral and the feed is improving, then of course, you know very well. Okay, so doctors or the patient and attender is very soon they want to remove the tube feed, of course, and they need to start the oral and they want to go home. So this is happening many of the cases, and in this case also the same thing happened. By hospital stay day 10, the patient is like yeah, patient is started with oral and FJ feed was side, but the very next day only oral mashed diet plus ONS started and FJ feed stopped. So hospital day 11, the oral mashed diet, but 1445 kilocalorie and 180 gram of protein with ONS, it's able to reach. So after that, the patient, yeah, this is the post-operative nutrition. We can see the whole hospital stay, how they recommended dietary allowance and how deficient we were, like, the energy and the protein adequacy. It is showing here well that POD3, they reached the target. POD4, I think 4 and 5, they reached the target. Then here and there, down and up, it was there, but patient got discharged finally on the 12th day, I believe. So nutritional advice has been given, like low fat, high protein, and soft liquid balanced diet. With ONS, high calorie, high protein ONS, we started. So recommended meal plan given 1900 kilocalorie and 85 gram of protein diet. Then after, from now our role is over, right? So then after, what is happening we need to take. So there is, like, we will give the normal brochures like tips of healthy eating and how to follow the diet, have good fiber and reduce the fat intake and protein concentration and do the ONS. This all counseling will go on. Then after, are we doing the real follow up or not? Okay, this is the question. Because this was the case study, we did a good follow up and the patient was okay with us. Even the patient was ready to come back for the initial stage, and follow up done well. So I think the first follow up done after 7 days. So initially, the patient experienced the bloating, and which is improved with the dietary modification. Then able to reach, I think, 1760 kilocalories and around 85 gram of protein, I believe. Then follow up to 1300 kilocalorie and 49 gram of protein. So here what happened, the patient understood that they are doing well, and the attenders also understood the patient is improving well. Then they start taking many, and they came out from the dietitian, what to say, dietitian role, and they start eating themselves. Okay, they had outside food, they had some fried food or some samosa and all at temporarily, like, change happened. So after consuming fried food, leading completely vomiting and reduced the intake, the patient is 2 3 days continuously vomit and all. Then after reduce the intake actually, and they didn't follow our instruction like to use the ONS. They stopped the ONS there. Because of that, there is a sudden fall of calorie protein was there. Then again, we called back them, we re-counsel the patient because they only came after 15 days because of the vomiting and all. Then we did the follow-up and we re-counsel the patient and went off. Then after 30 days, again we called back them. In between, there was 2 3 calls, but again we called back to the hospital. So third follow-up, the weight also increased actually, and intake reached up to 100 percentage requirement, and no further complication also not reported. So from that, we didn't do follow-up in the intake part actually, but after that, the patient came back for the body composition analysis without we called. Okay, so this was the follow-up one weight. The patient weight was 52.5 kg. Then it's fall down to 50 kg. Then after the follow-up three, it was 54 kg. So here the reason also it's written why it is up and down. Okay, then sorry. Yeah. Coming to the BCA profile, I think first in the admission time I shown what BCA profile again. So the across the BCA assessment, the patient demonstrate very gradual improvement in the overall body composition. So this is 100% because of the follow-up of a dietitian and the patient is willing to do the same. Otherwise, it is not possible. So total body water, protein, mineral content, and fat-free mass, intracellular water, extracellular, and skeletal muscle mass shows a progressive increase from the previous BCA. Here you can see that. So first BCA at the time of admission, then the second one done I think after 57 days, that is around the third follow-up of the oral intake. Then after we did after 87 days. Okay. So this is the graph showing the how the skeletal muscle mass or the total body water or the intracellular water and fat-free mass. So that means the lean mass, how it is improved. So you can see skeletal muscle mass improved like 20.9 kg to 23, and fat-free mass increased to 37 to 44.3 kg, and protein and mineral stores also showed a notable recovery. So body fat mass decreased from 13.8 to 12, so suggesting the improved body composition quality. So although several parameters remain below only, but it is a good improvement as per our calculation. So coming to the hand grip strength, here you can see how important the hand grip strength is, because hand grip strength assessment shows a consistent and clinically significant improvement in the strength and functional status following. It is not only because of protein rich food or this, they do good exercise also. The patient did a very good exercise. The physiotherapy is also going on the side again. So the recovery of muscle strength and the functional status following nutritional and physical exercise with interventions for sure. So right hand grip strength increased from 15.2 kg at admission to 30 after 87 days. So while left hand grip again 12.6 to 23.9 kg over the same period. So gradual gain were observed, but at discharge and each follow. But still it is in the lower side. So, okay, the adult man I think 42 to 50 it was. So still it is in the lower side, but yes, of course, the good improvement is there. So this is also highlighting the muscle function and nutritional status with effect of exercise and nutrition. Highlighting the hand grip strength is a valuable objective marker for monitor the recovery and treatment response. So as a dietitian, we need this response, right? We don't know about surgery, we don't want to know about the medication, how it is working, but we should know about how the nutrition working to the patient. So this part, this study is a good, that's why we chose this study. So coming to the take home message, again I need to tell like a point. If I tell like nutritional status, before the surgery strongly influence the post-operative outcome. But in this case, we did a good follow-up, so maybe because of that, we can manage the nutrition. But I'm not happy with other cases like this. It will not happen because the patient is like, the patient is completely malnourished before the surgery. It is very difficult to come back to the normal for sure within a time limit, but within 3 to 4 months we are able to catch up a while. But we need to do follow up again, and we need to give the good care. But the same thing, dietitian, doctor, and the patient is also should be come back, or they should also understand the importance of nutrition. Otherwise, it is waste of time for all. Then, yeah, early enteral nutrition in both safe and effective after Whipple procedure. Continuous monitoring for complications such as gastroparesis and pancreatic insufficiency and malabsorption is essential. Individualized dietary counseling improves the adherence and recovery. So, long term follow up and pancreatic enzyme replacement therapy critical role in maintaining nutritional status and quality of life. And PERT is a long-term nutritional consideration. So this case demonstrates the how the evidence-based nutritional intervention can significantly improve the recovery and function and overall outcome in the patient undergoing Whipple procedure. I hope I explain well. So if any doubt, you can ask in the chat box. Apart from that, we need to run with our major thing today's. Without any further delay, I think we can start our quiz.
Thank you so much, Dr. Ashwarya. It was lovely listening to you, and it's a big learning for us.
Very
All we shall we take the audience questions now, or we are going to the quiz first?
We will be going to the quiz first,
Okay,
Dr.
fair enough.
So
Fair enough.
now the quiz will be there. The
Yeah.
quiz, the link to the quiz is being posted on the chat group. In addition
Okay.
to that, each one of the participants would have received an email with the link to take the quiz. The quiz would take roughly 15 questions, should take about 7.5 to 8 minutes to complete.
Okay. So do
In the
we get them on the screen also? No.
No, it will come on the screen right now.
Okay.
Saurabh will be possibly presenting it on the screen. So the right now the quiz the on the chat group, the quiz link has been shared. On clicking the quiz link, people will be taken to the a separate window. They need not close the Zoom link. They will go on to something called the Slido quiz link, and there they can answer the quiz.
Okay. Okay.
And the questions will be simultaneously shown on the screen here as well. People will also get an email where they can join into the quiz. Only registered participants will be able to enter
Yeah.
into the quiz.
Okay. Even the link is shared through chat box also, so you can just click the link, and I'll play a video how to access. One
Yes,
second.
thank you.
Next, it is next to that second. That slide.
Oh, okay.
Are we playing a video, Kiran, to
Yes.
show? Yeah. Okay.
Go to the full screen version, please.
Yeah.
Yeah, we can play now. Yeah.
You'll need to enter the email ID and go to your email to pick the OTP for the quiz.
Yeah. ఇంకెప్పుడు ఈ సాఫ్ట్వేర్ కంఫర్ట్.
Started.
This is the video. The quiz will start once the video is over. Each question will have 25 seconds for answering. And when all participants have answered, the next question will come up. Otherwise, within 25 seconds, the next question would be shown on the slide screen. Once the quiz is complete, you can come to the back to the Zoom.
I think very few people only
Platform,
join.
and you will see, you'll be able to see NPC.
Yeah, do fast. Out of 100 people, only I am able to see only 15 to 20 people. So please do fast. So 38 is the number now. 50% I can say.
If anybody has any difficulty in joining the quiz, please check in your email through which you registered for the program. You will have the link there as well.
So we'll sharp 6:30 we will start for sure. So another 4 minutes I believe. Do fast. Still 39. Another 3 minutes. If any issues you can say, you can unmute yourself and tell if any problem you are facing, or you can through chat box you can write. You're able to see the chat box. It's 41 now, 42. 2 more minutes. Do fast. Very annoying persons' names are coming up. I'm happy. Too fast. Two more minutes. 47. Very easy question. You can all join without any delay. Do fast. 2 more minutes. One more minute. Still 49 people only. Try to join soon.
We are not able to see the screen. Can you share your screen, please, so that we know when the quiz starts?
Question.
Share the screen.
Okay. 51. Is it visible, sir, now?
Yes, it is visible. And are we starting the quiz now?
Yes,
6:30.
yes, yes. We are starting. Start. So first question. So first question, already you can see in the screen, a 55-year-old ambulatory carcinoma patient present with 15 kg weight loss in 3 months and low skeletal muscle mass, which GLIM phenotypic criteria alone already indicate the severe malnutrition. Phenotypic criteria. Second question. Why is BMI alone insufficient for nutritional assessment in pancreatic and periambulatory cancers? BMI overestimate the hydration. BMI does not identify the sarcopenia or muscle loss. BMI cannot be calculated post-operatively. So third question, in patients undergoing Whipple procedure, which nutrition screening finding would place the patient at high risk of nutrition? Like BMI 24 kg per meter square or 2% of weight loss in 6 months and significant weight loss in low muscle mass, mild hyperbilirubinemia only. Cannot see who came first. Yeah, which laboratory parameter in this case most strongly supported obstructive jaundice? Elevated creatinine, elevated ALP and bilirubin, low sodium and low potassium. 30 people answer, 33 people, 35 people. Some people not answering only. Why you people take so much of time to answer? Out of 51, only 41 people answer. Do fast. Which assessment parameter is most useful in identifying sarcopenia in a patient with normal BMI? Hungry strength, serum albumin, BMI, and hemoglobin. Very easy question. Still, people are not answering fast. See? Which assessment parameter is more that only no? It's not. Yeah. According to ISPAN recommendation, enteral nutrition should ideally be initiated within 24 hours post-operatively and after bowel sound return or only after oral intake begins and after drain removal. Good. So if the patient develop pancreatic exocrine insufficiency after Whipple procedure, what is the most appropriate nutrition intervention? High fiber diet, normal balanced diet, or PERT therapy? Any network issue? Why people is not answering? Still 41 people only answering out of 50. Which feeding formula is generally better tolerate if the early post-operative phase following pancreatic surgery? High fiber polymeric formula, semi-elemental, blenderized, or ketogenic? So, what is the recommended protein intake for critically ill post-Whipple patient? 0.8 gram per kg day and 1 gram per kg or 1.5 to 2 gram per kg, 3.5 gram per kg. Which of the following nutrient is considered as an immunonutrient? Lactose, arginine, fructose, and lysine. Which discharge diet is most appropriate following Whipple procedure? High fat, low protein diet, low fat, moderate to high protein diet, and high fat ketogenic diet or clear liquid diet? So the patient report bloating after discharge following Whipple procedure. What should be the first dietary advice as a dietitian? Small frequent meals throughout the day and restrict fiber and fluid. Increase meal size and restrict all the carbs. During follow-up, the patient experienced vomiting after consuming the fried food. What is the most likely nutrition-related causes? Lactose intolerance, excessive protein intake, or poor tolerance to fried food, and samosa is allergy. That can be is also a cause, right? Misleading. Which long-term nutritional intervention is commonly required after Whipple procedure? Lifelong TPN, permanent NVM, or gluten-free diet or pancreatic enzyme supplementation when indicated. Okay. So I believe this is the last question. A post-Whipple patient has regained weight, is tolerating 100% prescribed intake, and report no GI symptom. What is the most appropriate next recommendation? Discontinue the diet as the dietitian prescribed, or resume unrestricted intake of fried food, or stop oral nutrition supplement immediately? One more. One more, sir. I told wrong.
Momentarily.
Okay, so we are done with our today's quiz competition. Kiran sir can see.
I think we have. Thank you so much, Aishwarya, for conducting the quiz. Also, it's quite exciting. I'd request Dr. Harsh. I think there are some questions which have been posted in the chat as well, which we will take it up.
Thanks, Kiran. Just give me a second. I'm opening the chat box.
Yes.
I think these are the responses to the queries, questions we have asked that have been posted. If there are any questions, if you can please type them out, I would be able to read them. I'm asking the audience because I think we have posted the responses to various questions on the chat board.
Okay.
Yeah.
Okay. I think.
You think if we have any questions, audience, you could please.
So there is a question which has come in. Do we need to monitor fat-soluble vitamins A, D, E, K? From Shari Ajit.
Okay, here we are.
Who will take this?
Yeah, I think Dr. Aishwarya, would you like to take this? Do we need to monitor fat soluble vitamins, ADEK?
Yeah. We need to monitor for sure, but how to monitor and how we can find the deficiency is a big question actually, because most of the hospitals doesn't have that biochemical investigations. So we do like you see the deficiencies, the symptoms depends on that we can monitor it. Apart from that, there is no particular value to show it, as per my knowledge. So doctor is available. Doctor can answer.
Yeah,
Dr. Manish, you
I
are
would
on
like to
this.
take the question. Yeah. So my honest answer is that we don't do it
Yeah.
because most, as Dr.
If we
Aishwarya
don't
said,
persist, then
it is
yeah.
very difficult to do it. And as I pointed towards the very start, these Whipple's patient, most of them don't survive long enough to warrant a long term in sense, real long term, after 2 years, 3 years, kind of a dietary intervention. So, yeah, that is why most of the papers or these guidelines have not addressed this issue.
Hmm.
Compared
Okay.
to other cancers, let's say colorectal cancer or gastric cancers, etc., the even the quality of life data is very sparse and ripples because long-term survival is not very much over here.
Mhm. Okay. So
So
another
if I mean,
question which we have got is what dietary strategies help manage post-Whipple diabetes? Should I give it to Dr. Aishwarya?
What dietary strategies help to manage post with?
Post-Whipple diabetes.
Yeah, the same thing. What we explained till now, the same thing. We need to focus on a high protein diet, and we need to see the muscle loss, how much it is there. Of course, high fiber diet. Even the patient is diabetic, we need to follow all the diabetic restrictions with the complex carbs, and of course, high fiber and high protein diet for sure. So that's a simple thing. We need to follow the same diabetic rules for sure, even it is Whipple surgery or after any other surgery. Diabetic care is different, like diabetic care only. We need to follow the same.
Fair enough. So I hope you've got your answer. There's a question coming to Dr. Munish. What signs indicate complications that require urgent medical attention? I believe post-Whipples, that's what they want to ask.
pardon me, like I didn't get the question.
What signs indicate complications that require urgent medical attention?
Urgent medical intervention. I mean, I would say a bleed.
Hmm. Yeah.
Bleeding is the most, which really requires a very urgent care.
Mm.
So, I mean, the bleeding most commonly occurs in the first 20 odd days or so.
Mm.
So even if we discharge the patient on day 8 or day 10, we ask the patient, if the patient is coming off from a far off place, we ask them to stay nearer to the hospital so that if at all the patient needs a intervention, we can quickly do it in the hospital. So there's always a risk of bleeding. Even I mean, I've had a patient who, I mean, when I used to practice in Hyderabad, I remember distinctly remember a patient who had a gastrojejunostomy bleed.
Mm.
He had gone home. He was pretty okay by day 20. I mean, he got discharged by day 8. Day 20, he had flown back to Bengal. On around 30th day, I mean, 10 days after he reached Bengal, he had a bout of bloody vomitus.
Mm.
So luckily, I had a friend, a gastroenterologist near his place. So I asked them to go there and get endoscoped, and they could control the bleeding. So this happens, but not very commonly after first 10 to 15 days.
Hmm. So
Yeah,
that
someone
is
is asking a very difficult question. What is the line of action for a
accurate.
pancreatic leak after Whipple?
Yes, after it.
The honest answer is again, we don't do anything heroic or we don't do anything dramatic. We just take care of other things. I mean, as I told before, 15% of the pancreatic anastomosis do leak.
Mm.
I mean, about 30 to 40% of them do leak, and 15% have got what we call a clinically relevant leak. So, but the patient will have a drain which will be draining out some amount of pancreatic fluid. So, what we have to do is continue good nutrition. Don't restrict patients' intake, saying that okay, if we don't take food, that will give pancreas the rest of the pancreas rest, and it might the fistula might heal. No, it doesn't happen that way. You have to keep on giving them good food and hope that the fistula heals as fast as possible. Second thing, in a patient with post-operative pancreatic fistula, the risk of other complications is very high. Most of the patients who die following a Whipple die due to two complications. One, bleeding. Two, infection, sepsis. The denominator, the reason for both sepsis and bleeding, unfortunately, is a pancreatic leak. So we have to keep a close observational eye on these patients so that we are able to intervene as soon as the complication happens. This is all that we can do as of now for a pancreatic leak.
Any other questions? Am I missing on something here?
I think those were the questions, Dr. Harsh.
Yeah.
Why does ketoria occur after?
After Whipples.
Yeah, steatorrhea happens. It's basically a multifactorial. It is not just because pancreas produces less lipase. It is because the loss of duodenum kind of throws off the entire balanced digestion off.
Mm.
So that leads to, even though the enzyme is present, the normal activation of enzyme doesn't happen.
Yeah.
It takes a while for the pancreas and everything to get their act together. So most of the Whipple patients do not get a long-term pancreatic exocrine insufficiency because of two reasons. One, it gets better. Two, uh, the patients don't live long enough to don't live beyond 3 or 4 years or whatever to get that. But essentially, I have seldom come across a patient who has clear-cut features of pancreatic exocrine insufficiency after about 6 months or so. So my personal practice is I continue the enzymes for about 3 months because enzymes are very expensive. Pan lipase 1 month costs about 10,000 rupees. Most of the patients cannot afford it. So I don't give them beyond 3 months.
Fair enough. Any other questions?
Yeah, time is something. Okay.
Ladies and gentlemen, if you have any other questions, can you
Diarrhea, yeah,
just
one
how
very
you
interesting
manage
question
diarrhea
from
post-Whipple, I think.
Yeah, post-Whipple diarrhea is an uncommon entity in India because we Indians, as I told you, we encounter more periampullary cancers than pancreatic cancer, which are less aggressive than pancreatic cancer. Diarrhea happens when the celiac plexus or the nerve plexus around the superior mesenteric artery are removed during surgery. This we seldom do in a periampullary tumor, whereas in pancreatic cancer, we do it more often. So since we get less of pancreatic cancer, we do less of these kind of hyper aggressive surgeries. So diarrhea is less. In case diarrhea happens, again, it boils down to standard management, low osmolar feeds. And you have to give them Imodium, Lomotil, Ridotil, etc. Generally, it settles in about 2 to 3 months. Seldom have I again seen a patient who has diarrhea because of it's called neurogenic diarrhea uh, because of this beyond 3 months. Common problem in Western patients are getting too aggressive. West as well as
Yeah.
Japan.
Okay. This has to be enough. Okay. But if patient is not feeding on jejunostomy when the feed, I think.
Yeah. I thought of addressing this as a concluding message.
Yeah.
I'll come to it. I'll answer this.
Yeah.
I'll
Sure.
answer this. Yes, yes.
So, okay. Aarti says she'll wait for the answer. And
Thanks, Aarti.
yeah. Any other question, ladies and gentlemen?
Yeah, Dr. Harsh, if there are no other questions, I
There is
think I
one
will
to be
request.
answered. Yeah.
I
There's one
think
to be answered. by
Yeah.
Dr. Manish. Yes.
That I think
Yeah.
Dr. Monish is addressing it at the end. But before that, I would request if Ms. Aishwarya can share the leaderboard from today's quiz. I'm sure everybody will be waiting to hear this. See their names on the leaderboard.
Yeah. So I'll share it 1 minute. Share. Okay.
Okay.
So congratulations, Neha, Soni. All of you got out of 15 mark, but because of the time, uh, there are some variations. Congratulations, Neha, Soni, Hina, Fatima, and Suvashasri. What's the name?
Subhasri.
Suvashasri
Subhashri Bhattacharya.
Bhattacharya, Nandini, and Rishika Gupta. Congratulations, all the participants, and congratulations, these 5 girls who won the prize.
Okay, all five of them get the prize?
So the prize money
Yes,
will split or
Doctor.
everyone gets 5K?
No. Dr. Monish is increasing the budget. It is the first person gets the leader, Ms. Neha, will be given a Amazon gift voucher of 2,000 rupees, and others, the second and third will get 1,000 rupees gift voucher, and Nandini and Rishika, who are fourth and fifth, will get 500 rupees gift voucher. The total prize money is 5,000 gift rupees. Dr. Manish. I think it was quite exciting to see the responses, and even though there
Yes.
were some technical challenges, I really appreciate all the participants for taking such an enthusiastic response to the quiz. I understand some of the people could not get onto the quiz actively, but we got a fairly good response.
Fair enough. So that brings us towards the concluding part. Final words, Dr. Manish.
So, once again, congratulations to all the winners. It was really exciting. Great session. I learned. So, but at the end of the day, what I want all of you to go home with are a very, 3 or 4 messages. One, Whipple is a very major surgery. Think many times before someone embarks on it. So, assess the patient as thoroughly as possible. As Dr. Aishwarya put it forth, simple BMI is not enough. It's no more the standard of care. We have to have a multidisciplinary assessment of these patients. So, what I would suggest is have a body composition, biochemical, physical fitness, or the functional fitness, and the assessment. So, body composition, all of these patients without fail will have a CT scan. Sarcopenia is best characterized on a CT scan. I know there is a strong movement for bioimpedance analysis among, especially among the dietitians, but it has got its own problems. One, most of the hospitals may not have the machine. Second, it is not very useful in a patient who has got a metallic thing inside, like these pacemakers or prostheses. So BI is not very good, and even otherwise, it is not very sensitive for patients. We don't have cutoff values for patients beyond 65 years of age. Most of our patients will be more than 65. We're dealing with cancer, so BI is not a great thing. All these patients would receive a CT scan. We cannot do surgery without a CT scan. So please go and ask your radiologist and check the skeletal muscle index. We'll know if the patient has got sarcopenia or not. I mean, decreased muscle mass or not. Biochemically, you know that. Albumin, but is not a great marker, especially in the presence of inflammation, as most of these cancers and these conditions do have. If someone asks me what is one best test to assess the patient will come out of the surgery well or not, is 6-minute walk test. And all of the hospitals, anyone can make patients do a 6-minute walk test. What you have to do is ask the patient to walk as fast as possible without running for 6 minutes on a level ground, which you have to mark the distance. And there is a formula for both males and females on what is the expected 6-minute walk distance for their age, height, and weight. So we can calculate it. we have found that if a patient is able to walk less than 50% of the expected walk distance, he's at a high risk of complication and subsequent mortality. So please start doing 6-minute walk test. Uh, Hand grip strength is good, but 6-minute is my go-to test. Then none of these proteins or exercise prescriptions would work if you don't address the psychological impact of cancer. So please get a psychologist on your team. Insist on a psychologist to go and see this patient to see if the patient is depressed, anxious, and then we'll have to take measures according to his. The most commonly used score is a HAT score. We can act upon it. This is my first message. Second message, optimize the patient. Once you have assessed, you know if the patient is going to do good or bad. So, in all the patients where are doubtful, optimize the patient as far as possible before the Whipple. Let not Whipple kill the patient before the cancer kills him. So comes the role of prehabilitation. Third thing, post-operative feeding. To my understanding, at most of the places, the timing and the route of feeding is a surgeon's prerogative, surgeon's decision, whereas the content is a dietitian's decision. Right. So many times you will not be able to overrule a surgeon's decision on when to start feeding, but I might catch many of you surprised. But I remove the nasogastric tube in a Whipple's patient on day one. First day, the patient gets oral sips. Second day, oral liquids. By third day, patient is on soft diet. I know most of the surgeons don't do it. Do I do an FJ? I do an FJ on, let's say, 50% of the patients wherein I feel the risk of pancreatic fistula is high. Patient may have a leak, wherein oral feeding, oral tolerance will be less. In those cases, I do an FJ feed, but I don't use the FJ feed routinely. I use the FJ feed only if I'm not able to meet the calorie targets by oral route by day 3 or day 4. Right? This is my second message. Along with it, FJ feed is a problematic thing. We are not, our intestines are not used to receiving hyperosmolar, high volume feed directly into the jejunum. So the tolerance will be less. Patients will find it very difficult. With the typical complaint is, sir, पेट में गुड़गुड़ हो रहा है. It's very the abdominal distension that will make them even less tempted to eat by naturalis. So avoid FJ as much as possible. But then if a surgeon doesn't start the patient oral diet, then it's difficult for you, I understand. But if you see the guidelines, it is always oral diet from day one onwards. My fourth point is the dietitian's role doesn't end with discharge. Please insist with your surgeon and the hospital that we need to keep these patients on a longer follow-up. Have them on a longer measure, as I said, long-term nutritional issues. It's very important. And insist on having a high protein diet and with exercise throughout for these patients. I saw a question wherein it was like, what is the best tolerated food? I mean, I know many of you got the answer correct, but I don't know the answer to that myself because there is no way to, assess tolerance in a very scientific way. So what I do is I ask them, you eat whatever you want to eat. आपको खिचड़ी अच्छा लगता है खिचड़ी खाओ. You want an idli? Most of South Indians would prefer an idli. Most people in my part of the world would prefer an idli or what we call idiyappam, right? So I make them eat. The best diet for you is what your grandmother prescribed. Add some proteins to it. So, I mean, let's not be too strict and scrupulous with these diets. The idea is to enhance the recovery, not meet the calorie targets. Right. The idea is to give. I mean, I recently did a talk wherein I said ice cream on day 2 and a warm shower on day 3 or day 4 is something that would completely change the recovery trajectory of the patient because ice cream is kind of vilified. We all are under the impression that we can eat ice cream only we're completely well or we don't have any disease. So the moment I say to the patient, okay, you can have an ice cream, their entire perspective changes. From there, it's really upward go. This said, all of this holds true only to about 75% of the patients who don't develop a complication. If a patient develops a complication, yes, we manage on the merit of the complication. So ask them to eat as much as good food or whatever they eat normally as possible. This is my humble message to all of you.
Thank you so much. That was very lovely listening to this. And yes, we must enjoy what we eat, and eating we must enjoy. That is the message I am getting. Dr. Aishwarya, would you like to say a few words before we conclude the session?
Yeah, I know. I'd just like to add one thing.
Yeah.
Dr. Monish is, clearly exhibiting that he loves people to enjoy the food. And I
Yes.
think that's such a wonderful thing. As a patient, I have been his patient, so I know that he pushes you immediately. Go have what you like. I think that's a
Yes.
great thought. Thank you, Dr. Monish, for that
Pleasure,
insights.
pleasure.
Yeah, Dr. Aishwarya, any words from you?
You're on mute.
You are on mute.
So doctor explained well what is the thought actually. Even I want to say the same thing. I have only two things to inform all the dietitian. Just do follow up and tell the patient to follow their gut. That's it. If your gut is fine, you can eat anything. So depends on the symptom. You can see dietitians may tell to avoid, but what to eat that you should try to teach the patient because everyone knows what to avoid most of the cases, but what to eat is always a question because after going home they get doubt, I can eat this or not, I can eat. So don't confuse the patient with so many avoided things. You can tell limit quantity or based on your symptom you take it. If something is irritating you, something is hurting you after the surgery, please don't try to take. I always suggest like you try the same food maybe 3 times or 4 times, then the same symptoms if you are getting, try to avoid it. Otherwise you can eat each and everything, depends on your condition and basic symptoms what you get. So again, for dietitians, follow up is must thing. So do follow up with your patient. That is the only one thing we can do. We can help through the patient. But again, it is very tough the dietitian to manage each and every cases to do follow up. Again, the specific cases, the severe malnourished cases, they are not going to come back. Like that cases, you can make a call. Nothing wrong. Call them back, call them, give some discount and do follow up. That's it for the
Thank you.
better recovery.
Thank you so much, Dr. Aishwarya. Listening to you and Dr. Munish takes me back almost 3 decades, when there are new hospital was started at Delhi called PSRI, Pushpavati Singhania Research Institute. And it was headed by Dr. B.N. Tandon, who had just retired from AIMS and he had taken up that assignment. He said, what makes a patient feel good and happy, give him that food, you know, which ensures the recovery. So there's nothing like it, eat and eat what you like. Yeah, there are caveats to it. That's all right. So thank you so very much for enlightening.
Dr. Harsh,
Yes.
before we conclude, I'd request to share the
Yeah.
leaderboard.
Okay.
So congratulations once again to all the winners. And just to inform everybody, all the people who have participated in the quiz will receive their certificates with the scores.
You need to get that leaderboard.
There was also one request for the answers to be shared. If it's possible, we can share the answers as well. If that's a difficulty, I would request at least the leaderboard can be directly shared.
Then we're getting the questions here.
Yeah.
Yeah.
So congratulations to the winners once again. And if we can just show the the answers. I think this is the most tough question which was there. I think that's also come up the hardest question. In case it is becoming difficult to show the answers, we can share the answers to via email to all the participants.
Yes, I think people who
We
participated
can
and
hear, I think we can hear now. So the answers are going to share. It's coming, I believe, now. No? This, yeah. So I think you can see the answers now. This is the first
yes,
question.
yeah.
Next. Second question. Third one. The fourth question. Fifth question. Most of them answered right, but time was maybe the first and second, third. Yeah. Next question. Good. Yeah. Next question. 92% correct answer. Very good. Next. Yeah. Very good. Next. Okay. Good. Next. 98%. Good. Next. Okay, good. Yeah. Down it is. That's it.
That's it.
Yeah.
So I think everybody got them right. It was only a matter of fastest finger first kind of a thing.
Yes.
The one who showed the most alacrity in pressing the thing the right answer, probably otherwise. Because I see everywhere it was 93 to 97% correct answers.
Very good.
So that's what it is.
Next time you should make the questions difficult.
Little tough, very tough. Last time I hope we did little easy question because this is the first from Pulse. No, we gave chance to everyone.
Yeah,
Going forward, it
if
tough.
you make it too tough, the participation would decrease. So yeah.
We are generous quiz masters, I guess. That's what it is. So thank you so much. Thank you so much, audience. Thank you so much, Dr. Munish.
Thank you.
Thank you so much, Dr. Aishwarya, for taking out time. And you all are very busy people, but it was a very exciting evening. We learned a lot from here, and we look forward to learning more from you. So thank you so very much. Over to you, Kiran.
Thank you, Dr. Harsh. Thank you, everybody, for having joined in. A special thanks to Dr. Munish for that lucid presentation and talk when we had some technical issues. That was the thing which kept all the audience. Otherwise, we'd have lost all the audience in that gap. Thank you so much for taking that time to explain in detail and in such simple terms for all of us to understand. And thank you so much, Aishwarya, for that wonderful presentation and clear clarity with which you handled the session. I know we had some technical challenges, this being the first time. I really appreciate the effort you have taken in bringing up this case, putting it together. I understand that you have not been the best of the health today, but I really appreciate your support in doing this quiz for us today. I'd also take this opportunity to thank my team, all my colleagues for having put together this format. This is the first time we are doing a format where we are doing a live quiz. I also would like to thank the participants for quickly adopted to this quiz. I'm sure though we saw only 50 participants, there would have been many more who would have found it difficult to join on the quiz. Maybe we will need to popularize this format to make it more interactive and faster for the participants to conveniently take part in the quiz. I'd also like to thank my field colleagues for having motivated and met all the nutritionists and got them onto the platform for this quiz. A special thanks, Dr. Harsh, for, as usual, doing a great job on moderating event. And special thanks, shout out to the digital team for organizing this. Once again, I just want to reiterate Pulse Nutriscience and Pulse Pharma as a company. We are always committed to do good, not just in terms of quality products. We would also be really keen on working closely with the medical fraternity in improving the overall health outcomes through working on the academic and the scientific area of building up the knowledge of the healthcare practitioners and the allied healthcare practitioners through various of our initiatives. Thank you once again to everybody. Thank you.
Thanks.
Thank
Thank you,
you.
sir.
Thanks.
Thank you.
Thanks, Dr. Manish. Thanks, Dr. Aishwarya.
Yes, sir. Thank you, sir.
Yeah.
Thank you. Thank you.